So in this last part of chapter 6, I'm going to talk about diuretics. Diuretics are used to eliminate extra fluid from the body. We're going to first talk about the ones that are associated with cardiovascular disease, but there's a couple others I'm going to talk about that just because they're diuretics, we're going to just mention them in this chapter. So we talked about pulmonary edema, and also ascites in the body. And so that's where we need to get rid of extra fluid that is leaking out of blood vessels and into the lungs, into the abdomen, and causing extra workload on the heart. So that's the basic idea behind using diuretics, which eliminate this extra fluid in the body. I want to tell you that on page 137 of your book, this does talk again about edema and pulmonary edema and ascites, and it gets it right as opposed to a couple pages before in that box. So if I have totally confused you, you can use page 137 to look at if you need to look at something in your book. That one has the correct things going on the correct side of the heart. So there's several different types of diuretics we're going to talk about. Loop diuretics, thiazide diuretics, and potassium-sparing diuretics. These are the ones that are used in cardiac disease. And then these other two, osmotic and carbonic anhydrase inhibitors, are ones that are used with disease not associated with the heart. So what they do. The typical mechanism or mode of action, that MOA is my abbreviation for mode of action, is that they will prevent reabsorption in the renal tubules of sodium or potassium. So what is reabsorption? That is the kidney reabsorbing back the sodium and potassium so it doesn't get eliminated with the urine out of the body. It's picking it back up and taking it back into the blood. I'm going to have a link to an animation that you can look at, and that might help you to remind you of what is going on here. I'm not going to get into heavy duty into what happens in the renal tubule. You can go and revisit that from your anatomy class or in these animations. So it prevents reabsorption of the sodium and potassium, and so water will leave with that out of the body, or it enhances secretion from the kidney cortex back into the medulla and cortex back into the tubules. And again, water is going to stay in those tubules and leave the body. And then the other way that diuretics work is osmotic forces, and we'll talk about that more with the type that aren't associated with cardiac disease. But the end result is we're going to increase water loss, or what is called diuresis. And these are the drugs that cause, if you've heard that expression, peeing like a racehorse. Furosemide, which is the first one we're going to talk about, is actually used in racehorses to decrease the amount of fluid in the lungs. It's supposed to help racehorses breathe easier. It's a somewhat controversial drug used in horses, but that is a not cardiac related thing. It is just something that is used for racing horses. But yes, it will cause animals to pee like a racehorse. So here's our patient that we're going to use this for. This animal has ascites. The abdomen is somewhat distended, looks pretty full. You could also think that's a fat animal, but this animal, if you pushed on its abdomen, sorry, I pushed a little too hard with my mouse. If you pushed on the abdomen about there, you would find a fluid wave occurring. So we're going to use it to relieve edema in the lungs, edema in the abdomen, otherwise known as ascites. We're going to reduce the cardiac workload and just get rid of any type of edema that's going on. So we want to be careful if an animal is hypovolemic or has low blood pressure, because this is going to make either of those situations worse. So the first one we're going to talk about is furosemide, or Lasix. And this one is the one that is used most commonly by far. It is the most effective. It is very cheap. So for both of those reasons, we use it a lot. And we can tell owners to give it to effect because it's relatively safe. So we can give them a range of doses to give in an animal till it relieves symptoms. The typical thing this is given for is coughing due to pulmonary edema in cardiac patients. Our cardiac patients, when they lay down to go to sleep, the fluid will accumulate in the lungs. It will cause them to cough. And so this is the thing that we give to relieve this type of cough due to this pulmonary edema. And so we can tell owners they can give up to a certain amount in order to relieve that coughing. What these loop diuretics do is they work in the loop of Henle. The loop of Henle is where we have the most amount of reabsorption going on, and this is going to limit that reabsorption. So the reabsorption is going to occur from the nephron out into the medulla, mostly, a little bit in the cortex, but mostly in the medulla. And it's going to go back into the blood vessels, back into the circulation. Well, this drug inhibits that, so that the sodium stays in the loop of Henle and then attracts water to it, and that is going to be eliminated from the body. Now, the body likes to retain sodium. So in the distal convoluted tubule, so here's our loop of Henle. In the distal convoluted tubule, the sodium is actually exchanged for potassium. The potassium, though, it is a 1-for-1, and so it still keeps the water with it. And that is going to be eliminated from the body. So both fluid and potassium. Because of this, animals that are on these loop diuretics, on the furosemide, are going to be potentially hypokalemic, so low on potassium. And this will, if we're giving them digoxin, this increases the chances of digoxin toxicity. So we'll sometimes put animals on a different diuretic, and I'll talk about that one in a few minutes, or probably in the next section, all depending on how far we get. So we need to remember that when we're giving digoxin. We can use this in acute renal failure. It will be just fine. But once we get to chronic renal failure, and if we have damage to the proximal convoluted tubule, this can be hard to give this drug. And the reason is that there's an active transport system. It's not freely filtered through Bowman's capsule. There's an active transport system that brings it into the nephron. So if the proximal convoluted tubule is too damaged, that active transport system will not bring enough of the furosemide in to be effective. So we typically look at only acute renal failure. Sometimes giving furosemide, we can get ototoxicity and deafness, which is typically reversed once we take the animal off of the drug. We don't see that a lot, but it can occur. So another type of diuretic that we can use are thiazide diuretics. These don't work in the loop of Henle. They work in the distal convoluted tubule. They do decrease reabsorption of sodium, similarly to furosemide. But again, that sodium is exchanged for potassium, and so we do run the risk of hypokalemia. They do not work as well as furosemide, excuse me, because they act in the distal convoluted tubule. And by then, much of the sodium has already been reabsorbed in the loop of Henle. That's where most of that occurs. So we don't get as good fluid elimination. Because of that, we can use this earlier in stages of congestive heart failure because it's not going to change our electrolytes as much. We don't have the chance of causing hyponatremia as much, or kalemia, I'm sorry, the potassium. Um, and then we can also use this in association with furosemide if it becomes less effective. But it's not as good as furosemide. So here is what we will use if we are worried about the loss of potassium. We'll use a potassium-sparing diuretic, otherwise known as spironolactone. Spironolactone, its mode of action is it is a competitive antagonist of aldosterone. So this is most effective when an animal is in congestive heart failure, has the renin-angiotensin system activated and aldosterone being released. And if you remember, aldosterone is going to increase blood volume by causing sodium retention. If we are a competitive antagonist, we're going to basically block the effect of aldosterone. Sodium is not going to be retained. It's going to be eliminated out of the body. And in this case, it stays in the lumen, keeps the water with it, and it is going to leave the body. So sodium is excreted with spironolactone, and potassium is going to be conserved. When do we use spironolactone? We're going to be using it if we're concerned with hypokalemia, when we're using other drugs for congestive heart failure. And if we do not get the response we want from thiazides or Lasix alone. So we sometimes are using it in addition to other diuretics. And as I mentioned, we already have to be in congestive heart failure. We have to have the renin-angiotensin system being activated. This link you can use to watch an animation that talks about how diuretics work. So some other drugs that are used in cardiovascular disease are aspirin, bronchodilators, sedatives, and tranquilizers. We'll talk about bronchodilators in the next chapter, in the respiratory chapter. Remember aspirin, we talked about it in the anti-inflammatory chapter. We typically use this in situations where we're worried about blood clots associated with a heart condition or heartworm disease. I'm not going to mention much else about aspirin. So sedatives and tranquilizers are sometimes used when we have a cardiac patient that we're worried about being overly stimulated because their heart is not functioning well. We don't want to stimulate their sympathetic nervous system. We'll put them in an oxygen cage. We may give them a tranquilizer. And will help them to breathe easier. Sometimes they will swallow air. That's called aerophagia if they can't breathe well. And so for all those reasons, we want to put them in a quiet area of the hospital and keep them calm. And sedatives may be part of that. Lastly, I'm going to talk about two other diuretics. These are not associated with cardiac disease. The first one is mannitol. It's a large sugar. We give it IV. It helps to relieve the fluid in the body in different areas, and in particular we'll use it for cerebral edema in head trauma. Swelling of the brain is not good because it's encased in a bony case that does not give, so we'll want to get fluid out of it as quickly as possible, and mannitol works very effectively for that. We can also use mannitol in situations where we have poisons or excess drugs. It will also help to eliminate those quickly from the body. Lastly, carbonic anhydrase inhibitors. Acetazolamide is the one that we're going to talk about. It is not used systemically. It is only used to reduce the pressure, intraocular pressure, in cases of glaucoma. So this is just a particular use. It tends to draw water out of the eye very effectively.